So this Pearlcast is going to deal with the diagnosis of overactive bladder. So obviously most people who have medical training know how to do a history and physical, so what I'm going to talk about more is the tailoring of your usual history and physical to diagnosing a woman with a complaint of overactive bladder. So obviously you'd want to ask about all bladder symptoms. So that would include how often they're going to the bathroom at night, leakage with activity or stress incontinence symptoms, urge incontinence symptoms. You'd also want to capture what their fluid intake's like. Are they doing things in their diet that could be associated with overactive bladder, such as caffeine or alcohol? Obviously, you would get a medication list. You want to know if they've had urinary tract infections, and you want to ask about neurologic disease or injuries that could lead to neurological disease. So you would do that in addition to doing your comprehensive history on a patient. So what are the pearls of the physical exam? Obviously, again, for any new patient you have, you'll do your head-to-toe physical exam. But specifically, when you have overactive bladder complaints, you want to look for edema, especially if they have nocturia, because they will mobilize that edema at night. You want to assess for pelvic organ prolapse. You want to assess the pelvic floor tone, which may give you an idea of neurological disease, or if they have hypertonicity, that could be associated with overactive bladder. You'd want to do some neurological testing of the nerve roots to the bladder, S2 through S4, and you can do that through pinprick sensation and different reflexes such as bulbocavernosus reflex or anal wink. And obviously, something to keep in mind, especially with older patients, is assessing cognition. An easy tool for that is a mini mental exam. And then, as we mentioned with depression, you can use any kind of simple depression screening tool to maybe clue you into that diagnosis. I'd like to read now to you the guideline statements with regards to diagnosing overactive bladder that come from the American Urological Association and SUFU statement in May 2012. Number 1, the clinician should engage in a diagnostic process to document symptoms and signs that characterize overactive bladder and exclude other disorders that could be cause of the patient's symptoms. The minimum requirements for this are a careful history, physical exam, and urinalysis. Again, history, physical exam, urinalysis, and that's all you need to diagnose overactive bladder. In some patients, this is the second statement, in some patients, additional procedures and measures may be necessary to validate an OAB diagnosis, exclude other disorders, and fully inform the treatment plan. At the clinician's discretion, a urine culture and or post-void residual assessment may be performed, and information from a bladder diary, it only needs to be a 3-day diary, and or symptom questionnaires may be obtained. But those are optional to make the diagnosis. Urodynamics, cystoscopy, and renal and bladder ultrasound should not be used in the initial workup of an uncomplicated patient. And OAB is not a disease. It is a symptom complex that generally is not a life-threatening condition. After assessment has been performed to exclude conditions requiring treatment and counseling, no treatment is an acceptable choice by some patients and caregivers.